Hi there. So I just want to thank everybody for joining on with us today. I can see the numbers sort of ticking up as people, just as it comes past 12 o'clock here. Purpose of today's program is to discuss a little bit more about transitioning from the FIG to FHO and what that would mean for you and your group. So let's just dive in here and we'll get going. Some quick facts before we really get into the discussion today is family physicians are now better compensated in Ontario than anywhere else in Canada. More than 75% of all physicians say their pay does not align with the care that they deliver. And Ontario physicians are generally not strategic in how they are paid due to a widespread lack of clarity around the OHIP funding models. They're set up in a way that has been, it's so complex really, and that they've changed so much in the past decade that it's difficult for people to sort of navigate how to best utilize the tools and tricks available to them in each of the models. So the purpose of today's program is to increase your understanding of the FHO model, compare the FIG versus the FHO model, and then go into a little bit more of FHO education so that it will allow you to hopefully make a little bit more of an informed decision on whether or not the FHO is really right for you specifically and for your group. A little bit about who we are and what we do. Sears Consulting Group, we're founded in '94. We're 50 employees headquartered in Toronto. And we provide practical business solutions that allow healthcare professionals to concentrate on what they do best, which is provide quality patient care. We have our specialized business units, our office lease negotiations that happen over 500 per year all throughout North America, as well as billing support and operational consulting for physicians for both groups and individuals. Now, what we do in the healthcare consulting division is we help physicians and staff to optimize income, increase efficiency, and flexibility within offices across the province. Our clients include physicians and office managers operating in all models, FIGs, FHOs, and FITs across the province. As I say, we assist groups and individuals, and the average return for physician groups leveraging Cirrus services is 30%. And the hours saved by engaging Cirrus is approximately 1 full-time work week per month. We've assisted 672 healthcare practices across the province to really push them to that next level of making sure that their businesses are really operating in a way that is aligning the pay with the care that they deliver. And we've established a collaborative relationship with over 2,100 physicians and counting. So why was the FHO introduced? Let's sort of strip this back a little bit so that we really have a good understanding of why this model is set up the way that it is and how we ultimately got here. Now, the state of primary care from the 1990s until now, we all know that there was big problems that happened in the 90s with the hard caps, lots of people going to the U.S., not a ton of residents choosing family medicine as the specialty they wanted to go into. So some of those key points were there were increasing costs of healthcare, aging population, there was a high use of urgent care facilities because of accessibility was such a large problem, and the focus was really on reactionary medicine and not preventative medicine. And the models were built in a way so that activity was really based on throughput. The more patients a physician saw in a day, the more income that they would earn. And also, at the same time, there was diminishing access to healthcare. So both of these things sort of created this perfect storm, and ultimately, the patients ended up suffering. 1 in 5 family physicians were accepting new patients. In 2002, 1 million Ontario residents were without a family medicine physician. And by 2010, an estimated 2 million orphan patients were out there in Ontario, and there were fewer new grads pursuing family medicine. So you'll see here, this is physicians per 100,000 people within Ontario. You can see in '95, the ratio wasn't too bad, 186 physicians per 100,000 people within the province. But slowly, as the political pressures started to come down, the models weren't really working to the physician advantage or the patient advantage. We saw that number in massive decline, where you can see really it was in 2002 where there started to be big problems. That was the largest point where there were accessibility problems within the province. However, in 2003 was when the Family Health Group was introduced, which ultimately allowed the patient enrollment models really sort of re-energize the primary care community in Ontario and allowed for these numbers to start ticking up once again. Now, the patient enrollment models. All of the boxes here outline all of the different payment models for physicians across the province, starting in fee-for-service at the bottom left, up to family health teams on the right. You can see that as each step happened, there's more and more of an interdisciplinary care team that is sort of integrated with all of these models. And as the models started to move from fee-for-service all the way up to FITS now that there are improved patient outcomes. And the reason for that is because there are a lot more preventative care measures and incentives put in place to try to drive behavior from the physicians. Now, the reason why FIGs, FINs, and FHOs, the groups highlighted in green, are there because majority of physicians in the province are practicing within these models today. However, most people are still practicing with the fee-for-service mindset. And in our experience working with physicians across the province, we really think that the reason for this is because this entire transition occurred within 1 decade. Went from fee-for-service to all of a sudden we are practicing in FIG models and FHO models where all of a sudden it's not just about swiping the card and about the throughput coming through the office. Now there are all these other programs and levers to pull to ensure that you're being paid properly for the care that you're providing. From a policy standpoint, the fact that all of this happened within 1 decade is remarkable. Now the trends in patient enrollment adoption, this is on the physician side. So you'll see here that the red line is for fee-for-service, the blue line is for family health group, and the FHO is the green line. Now you'll see here in April of 2003, when the FIG was first introduced, that's the blue line, you can see that there was a dramatic drop in fee-for-service. And this is because a lot of you that are on the line today, I'm sure, can attest to this, that a lot of it had to do with all of a sudden there was a little bit of predictable income on the table for you through the comprehensive care payment, as well as, you were being incented for things like providing care after hours. So people that were already doing this really jumped on board with the FIG model sort of right away. You can see that the FIG really started to overtake the fee-for-service model in April of 2006. But at the same time, that's when the FHO was being introduced. And at the end of this graph on the right-hand side, you can really see that the FHO started to overtake the FIG model by physicians within the province. And now the majority of physicians are practicing within the FHO model in Ontario today. Now, in the last round of Ministry of Health negotiations, there was a lot on the table to potentially have impact. Some of the main changes were to FIG physicians, unfortunately. There was a greater impact on the FIG physicians than the FHO physicians. The average impact for a FHO was 2.4%, and the average impact for FIGs was 4.4% reduction. Some of the reasons for this were due to the $1 reduction to the AO07. This only impacted FHO doctors by 15 cents, as AO07s are all considered in basket, which we'll talk a little bit more about down the line. Also, the implementation of the periodic health visit. Periodic health visit reduced the AO03 from $77 to around $50. However, all of that activity was in basket for FHO physicians, so there was less of a financial impact on a day-to-day basis. So what is the FHO? How is it different? What are the main drivers that are very sort of different in theory between the FIG and the FHO model? So the FHO is a payment model where physicians get paid a monthly payment for every patient on their roster, regardless of if you see the patient or not, as opposed to being paid for each encounter as you are in the FIG. Think of it as being prepaid for agreeing to provide sort of that standard level of care to all patients. And rather than being paid to drive volume in order to generate and maximize revenue, physicians are now incented to focus on medically necessary visits, preventative care, and complex care. The model is set up in a way to try to drive this behavior through the different programs available to you within the FHO model. The main difference here, as I say, is really throughput versus access. In the FIG, and the only way to really generate more income in the FIG is to see more patients, sort of work longer hours. Where in the FHO model, the main difference here is about accessibility. You've made a commitment to care for X amount of patients. Now it's about providing access and the right care to those patients in order to really pull the levers that are available to you within the FHO model. So to drill down a little bit further, really this comes down to fixed payments and performance-based incentives. In the family health group, everybody has access to the comprehensive care payment. That's the small payment that you receive for rostering patients. In the FHO, you get the comprehensive care payment, but you also get the base rate payment, and that's really the bread and butter of the FHO. Within the family health group, the majority of billings that go through are actually done on a fee-for-service basis. That's where the majority of income is generated from. But you also have access to patient enrollment incentives, the preventative care program, and bonuses and premiums across 5 categories. In the FHO model, you not only have the fee-for-service billings, patient enrollment incentives, patient care, or preventative care, you now have access to bonus and premiums across 8 categories, the access bonus, shadow billing, and you'll be paid for CMEs. And the main piece here is really that there's between 70 and 75% of all income in the FHO is fixed. Now here's an illustration of the FIG versus FHO income breakdown. The main piece I want you to notice here is the majority of income in the FHO model is fixed. That's done through the roster. Versus in the FIG model, there's a smaller portion of income that's on a fixed basis. Therefore, things like being away for 2 weeks within 1 month is going to have a dramatic difference on your take-home than it would be in the FHO, as there's a larger portion of income that is guaranteed within that FHO model. Now, the average Sears client sees an income increase of 20% when transitioning from the FIG to the FHO model. That's why you see that higher dollar value in the FHO model. Now let's talk a little bit more about FHO education. Now this is an illustrative view of the FHO income stream breakdown. This won't be the same for everybody, but it does provide you with a little bit more visibility in terms of the typical breakdown of the income streams available within the FHO model. So the key piece here is that there are 6 streams available to you within the FHO in order to generate income. The first and largest is the capitation payments. This is that fixed payment for agreeing to care for patients on an annual basis. Then you also have access to fee-for-service billing, access bonus, shadow billing for all in-basket services. That's where you would receive 15% of the dollar value for all in-basket services. For example, in AO03, you would receive 15% of that dollar value. Preventative care bonuses and special premiums. We're going to walk a little bit more in detail into some of these specific pieces. Now the capitation payment. This is what I keep referring to as the fixed payment and often referred to as the salary within the FHO model. It's a monthly payment that is provided for each rostered patient and is adjusted based on age and sex. It covers 126 fee codes, which represent the majority of comprehensive care services to patients, and these are referred to as in-basket services. These are your AO07s, your AO03s. It's also important to notice that the age-sex breakdown, the difference there is that a 65-year-old female is going to earn you more in capitation than a 17-year-old male. And the reason for that is because generally more services are demanded by that 65-year-old female than the 17-year-old male. All other services provided to rostered patients are considered out-of-basket services and are paid out at 100% of the fee-for-service value. Diabetic care is a great example of this. Fibromyalgia, congestive heart failure, all things that you have the ability to bill the full fee-for-service value on. Now the capitation payment breakdown. This is where I was giving the example of the 65-year-old female versus the 17-year-old male. This is really where you see each different age bracket along the bottom and the dollar value on the left-hand side. Now, you see as the patient ages, so does the capitation payment that you receive on an annual basis for caring for those patients. Now, the average patient in Ontario earns about $215 per year. So if you want to do some quick math, you want to take your current roster size and multiply that by $215, and that's a rough ballpark number for your salary. Now, what does the fixed income give you? As I say, this is the largest portion of income within the FHO model. Really important to ensure that it's being well cared for and well managed. It gives you income predictability, which is incredibly valuable. All of the clients that we work with, this is one of the largest pieces that people enjoy when they make the switch. Increased flexibility. It helps to mitigate against peaks and valleys of billing patterns or vacation. As I say, if you do decide to go on a week's holiday in March for a family vacation, you're not going to see such a dip in income because you're not in the office. It also eases pain during large transitions, for example, EMR implementation, where there would be sort of a large new project coming into a clinic could take up a lot of time, and having that predictable monthly income really allows for you to sort of you could really focus on that EMR implementation, for example, without having such a hit to your income during that time. Another piece here, which I don't have on the slide, is that the fixed income is something that is really valuable to new graduates as well. From a recruitment standpoint, the FHO really is a model that a lot of the new grads are looking to, as it really provides that sort of predictability and stability within the first few years of practice. Now, looking on the right-hand side, you see the financial impact of rostering. Let's look for the number of patients, so anywhere from 600 patients to 2,400 patients. Let's take 1,800. The annual fixed income for those 1,800 patients on average would kick out around $387,000. Now remember, that is only, on average, 70% of your total income potential, because that is just the portion that's derived from the roster. Now, we always ensure rosters are well managed through the transition period and thereafter. It's the greatest income generator within the FHO model, but we don't just start to think about the roster at the day of transition. There's so much work that can be done within the FIG model to ensure that, A, you're not only getting that capitation, that comprehensive care payment today that you're all eligible for, but B, the day that you transition, you have everybody on your roster that you currently care for. There's a lot of FIG physicians out there that, let's say, care for 2,000 patients and only have 600 of them rostered. And that's a key exercise that needs to happen during that transition period. Fee-for-service billing. Think of this as you do have the ability to bill fee-for-service for enrolled patients and non-enrolled patients. For enrolled patients, out-of-basket services, that's 100% of the fee-for-service value. That's for things like your diabetic care, your fibromyalgia, your congestive heart failure, your smoking cessation. So this is a great income generator in the FHO model. The reason for that is because you're not only getting the capitation payment, you're getting everything else that's out of basket on top of that. Then there's the non-enrolled patient side. Let's focus here for a second. You can provide in-basket services to non-enrolled patients. You'll receive 100% of the fee-for-service value because these patients aren't rostered to you. This is just your standard fee-for-service activity, as well as out-of-basket services, which are also at 100% of the full fee-for-service value. The reason why the in-basket services is highlighted in red is because it is subject to a group-wide hard cap. That means every physician that is part of the FHO has around $60,000 per year that they put into a group-wide pot, basically. And if somebody goes over and bills $61,000 in in-basket services to non-enrolled patients, but the majority of the other physicians are only billing around $20,000, which is the average, then there's no impact to the group. The reason why the hard cap is in place is from a ministry perspective. They don't want physicians to roster patients that they never see and then keep frequent flyers on a fee-for-service basis. It would be really taking advantage sort of both sides of the system. However, there are also an important point is that there's no hard cap in the first year of practice within the FHO. And in my experience, we actually have never seen a group come close to the hard cap. Out-of-basket services. So some key areas here. In the FHO model, you not only have access to the roster payment, but everybody that's rostered to you, there's also going to be a number of codes that land outside of the basket that you receive the full fee-for-service value for. For example, diabetes management, smoking cessation, after-hours billing. Now, we guide all of our clients by assisting them with determining the type of care that they typically provide and really giving them some key takeaways and some key codes that they can use to really drive up income within the FHO model. On the right-hand side, you see a visual of one of the cheat sheets that we refer to it as one of the pieces that we provide our clients to assist them with what to bill out of basket to really drive that income. Diabetes management. Let's take a closer look at this just as a small little case study. So the KO30, you can bill up to 4 times a year, around $40 per visit. Once you have those activities done, you can bill for the flow sheet, the QO40, at $60 per billable once per year. Now the maximum per patient annually is $216 for all of that diabetic care. Now the average number of patients that would be diabetic within a roster in the average size of 1,500 patients would be anywhere from, let's say, 120 to 140 patients within a 1,500 roster. The total fee-for-service revenue potential just from this diabetic piece alone is $26,000 to $30,000. That's what's currently available to you within the FIG model. But what I really want to highlight is the total diabetic patient value in the FHO goes from $52,000 to $60,000, virtually double. And the reason for that is because you're not only receiving income from the roster, you're also receiving all of the diabetic care on top of that. Smoking cessation is another good example of this. So the E079, billable once per year, and the K039 and the Q042. Smoking cessation is a little trickier, but it can be a really good income opportunity for you. All codes can be billed in addition to an assessment, and the maximum per patient annually is $97 for all of that smoking cessation care. Same example here, number of patients on average of a roster of 1,500 would be around 155 patients that would qualify for the smoking cessation bonuses. So the total fee-for-service revenue potential, same amount that's available to you in the FIG, would be $15,000. However, you need to add that to the total patient value by adding in the capitation payments, which pushes it upwards of $50,000. The access bonus. Let's talk a little bit further about the access bonus that is available to you within the FHO model. Now, I understand, and having worked with a number of physicians transitioning from FIG to FHO across the province, this is one of the main concerns that people have when transitioning. And I think that there needs to be a little bit more clarity around the access bonus program, which hopefully you will leave with here today. So let's talk a bit further about what the program is, how it works, and some best practices to ensure that there's not a lot of outside use activity happening in your practice. So the access bonus. It's a bonus paid on the level of access a physician provides to their overall roster. The average bonus potential is $62,000 per year. Now this is over and above the capitation. That $62,000 is reduced dollar for dollar for FHO in-basket services to enrolled patients provided by a physician outside of the FHO. For example, if you had a patient that was rostered to you and they called your clinic, couldn't get in to get an appointment, and they ended up at the walk-in clinic and a physician at the walk-in clinic billed an AL07, that would reduce that $62,000 by $34. Now, it's also paid out based on group performance. Negative members of the group do impact those who are positive. This is really where we often use the analogy that you really go from it being more of a solo sport in the family health group to really a team sport within the FHO. And the access bonus is certainly an area that really comes into a little bit more of a team environment. For example, if that $62,000, if there was one physician within the group that after a 6-month access bonus period had $5,000 left over out of the $62,000, and another physician in the group was negative $5,000. The person who's negative, from a ministry perspective, does not have to pay that money back at this point. However, that would negate that $5,000 that the one physician within the group has earned, so both doctors would receive nothing. This is something that we always work with our groups to ensure that a fair way of distributing the group performance is set up. For example, some people pay out based on percentage of overall positivity they're contributing to the pot, or some negative physicians will pay back the amount that they're negative, so everybody will get full payment for their access bonus. There's a variety of different ways to ensure that the access bonus is distributed fairly. So outside use management risks. This is an important piece because the outside use is what drives down your access bonus. Now, it's hard to control. As you imagine, it's hard to control patient behavior. Something that is always going to be a concern and is one of the largest concerns when transitioning from FIG to FHO. Also, patients are unaware of the impact when seeking care outside. They don't necessarily know that although they're rostered to Dr. Smith, you know, they have a walk-in clinic right beside their office and they're sick one day and decide to go to that office. They don't necessarily know that that's impacting you negatively. No open appointments. So this is a very important piece. As I say, in the FIG, it's about throughput. In the FHO, it's really about access. And not having any availability for the patients that are rostered to you is a problem, because then those patients are going to go outside of the FHO to receive that care, which is going to drive down your access bonus potential. We always encourage our physicians that we work with to really work on a 70-30 split, 70% booked appointments, 30% open appointments. Referral patterns, also incredibly important. Now, specialists do not contribute to outside use. That's an important key piece. However, anybody that's CFPC certified, for example, a sports medicine physician or a CFPC certified somebody that's doing some psychotherapy that doesn't have the focused practice designation within your community will impact you in terms of your outside use. So things like psychotherapy, sports medicine, pain management, addiction services, as well as the walk-in clinics will impact your outside use. All of the physicians and the clients that we work with, we never encourage anybody to change their referral patterns. We don't want you to ever compromise the care that you provide to your patients by referring to the person you think is best to do the job. But what we want you to do is we can assist in showing you when it makes sense to see that patient on a fee-for-service basis instead of through the roster. Another big piece is just patient education about the FHO. Patients are unaware of after-hours care that's available to them by being a FHO patient. We always really try to work with the staff and the physicians to ensure that everybody gets the message every time they come into the clinic that there's after-hours care available to them because they're a patient of the entire FHO. Our outside use management strategy is second to none. We have really moved the needle with a lot of the clients that we work with in terms of having an effective outside use management strategy. The way in which we do that is by utilizing our software to determine patients' outside use patterns and trends. Within the FHO, every month with your RA, the ministry will provide you with an outside use report. This will show you all of the patients that are rostered to you that have gone outside to receive care. What it doesn't show you is at what point it makes sense to see somebody on a fee-for-service basis, and they don't show this information to you rolling month over month. So it's really hard to pull out the trends and patterns. Our software is able to do this. We analyze that data to determine which patients to move from the roster to fee-for-service. If a patient has gone outside for more services than their capitation is on an annual basis, that's the point we will tell you to de-roster that patient. Educating patients on what it means to be an FHO cannot be devalued. It's incredibly important that patients really understand, as I say, that they have access to that after-hours care. And ensuring frontline staff are delivering the key messages about access. Your staff are incredibly important to ensuring that all of those key messages are delivered. And I can't emphasize enough what an important role that they can play in the success of the transition of the FHO. Now our outside use analysis. So here's a couple of screenshots of what's included in this analysis. We show the pie graph here on the left-hand side shows you the codes that contribute to your individual outside use. And on the right-hand side, you'll see that we also show you the days of the week that contribute to the outside use. And the reason why we show that is because it does help with scheduling patterns. If you take Wednesday mornings off every week, and your outside use spikes on a Wednesday, then we want to make sure that we have open appointments on Tuesday afternoons and Wednesday afternoons in order to try to sort of ensure that we're catching all of those people that are trying to get access to the same day appointments within the office. So we'll show you what days of the week peak your individual outside use, what codes contribute, who the patients are, and at what point it makes sense to see someone on a fee-for-service basis. Special premiums and CMEs is another piece that is available to you within the FHO model. So in total, there's 8 separate categories that you have access to. Total potential of $37,000 available across all of these categories. As well, you now will be paid for CMEs, a total potential of $2,400 per year and 24 hours that you can submit for. So special premium. So within these 8 categories, in the FIG you're eligible for 5 of these. In the FHO, you're actually eligible for 8. So we know, and having worked with tons of clients across the province, that not everybody delivers care in all of these categories. So the message is not to start doing labor and delivery if that's not something that you do. But the message is that if you do office procedures or prenatal activity, or you have bipolar schizophrenic patients, that you're billing effectively for that care in order to capture the bonus. Now let's walk through a brief case study of a group that we worked with that may allow you just to have a little bit more perspective in terms of what the common process is and how Cirrus can be helpful throughout that process. Now the background. In 2009, Cirrus and a group of 24 southwestern Ontario-based physicians are located across 5 clinical sites, started working together to transition the group from FIG to FHO. The group's motivation was to increase income, work-life balance, and flexibility. Now, some of the goals of the group were to transition to the FHO within a 6-month period. How we did this is we actually prepared this entire group to ensure that not only were they ready at day 1 of the transition, but the FIG was being optimized months leading up to that transition. As you can see, based on earlier slides, there's a lot that's built, the foundation of the FHO is really built on some of the FIG pieces as well. The roster, the preventative care program, some of the Q codes that are available. Let's make sure that all of those pieces are working well within your office prior to transition. So we worked to optimize the FIG in preparation for transition, and we led all of the ministry required documentation to ensure that sort of things went off without a hitch the day that switch was flipped. The next goal was to stabilize the access bonus within 1 year. As you can imagine, and I'm sure some of the common objections or concerns out there are, I have a roster of patients, I don't know who's currently going outside or not. Because you don't have visibility into this as a FIG physician, this is a piece that we really have to work together on within that first year. How we do that is we take all of those outside use reports and we highlight the chronic contributors to outside use. Those that are going to Dr. Bernstein, addiction services, those that go to walk-in clinics all the time, those are people that we really need to take off of the roster, still can deliver care to them, but just on a fee-for-service basis. Also, educating patient education outreach, putting together a bit of a marketing plan to roll out within your clinic to ensure that all patients are aware of the access that they have by being a FHO patient. Now, the access bonus capture rate. So as I say, on average, each group or each physician within the group had $62,000 available to them within the access bonus. So the capture rate is really looking at how much of that $62,000 per doctor did this group receive. So in March of 2010, the day they went live, they were negative 13% on a group-wide level. You can see in March of 2011, 2012, and 2013, we've been on a massive uphill climb, which is excellent, 3% to 9% to 22%. We're currently halfway through an access bonus period. The next period ends in September. We're currently capturing 36% of that access bonus potential. We're confident by continuing to work with this group that we will be able to get them up to 50%. Now, some of the next pieces were to finalize the FHO governance agreement. As part of becoming a FHO, you are required to have a governance agreement. Things within this are specific to the group. So they provide a template, but you really do have to work with your group to determine individually the things that are really going to work for your group. It's going to be a very different governance agreement for a group of 30 doctors versus a group of 3 doctors. What's in this is really some guidance around and some rules around, i.e. how much vacation people can take, what happens when somebody wants to retire, at what point, if you are going on sick leave or mat leave, how long do you have a locum for? Rules like this that really make it fair, because it is more of a team sport within the FHO. Increased bonus and premiums. So now we had all of the building blocks in place. Now we want to look to optimization. So we guided the physicians on ways to increase bonus billing potential. We look at their individual RAs and billing patterns and pull out ways that they can go back and bill for things, or in the future ensure that they are, for example, if they're doing all of that serious mental illness care, that they're billing properly for that in order to get access to the bonus. Now, since working with them, we've identified bonuses and premiums in excess of $300,000 for this specific group. With this group, because it was quite large, we actually undertook all of the administrative requirements as well. So we optimized the FHO administration, banking, and scheduling for the entire group. Overall, typically we work around 48 hours per month in operational support. And we do this with a number of other groups, so we do have it down to a science. Ongoing assistance and maintenance for staff and physician is our next goal, and sort of ongoing. This cannot be devalued. There's so much work that we do here for all staff members and all physicians to ensure that they have access to a subject matter expert at any time. People call us. On average, this group specifically, 9 hours per month, we had total questions coming in from staff about rejection codes that are happening, new codes that have come out, how do I bill properly for that? So we are always available as a helpline to all of our clients that we work with as well. Now, all in all, to sum up this specific case study, physicians increased income by 18% above the average FHO physician after transition. And the reason for that is that all of a sudden you have access to a group of people at Cirrus that work to really offer one-on-one assistance to make sure that your practice is really going from the day of onset to really ensuring that you're optimized. The FHO has a greater handle on how to deliver high-quality patient care without dramatically shifting their office environments or practice style. We don't want to come in and have people sort of rewrite the rule book of how they traditionally practice. What we want to do is align the care or align the pay with the care that you currently deliver. So some key takeaways for today are Within the FIG model, some things I really want you to be aware of and things that you could sort of do today that would be value adds for you would be to review the bonuses you're eligible for in the FIG across 5 categories. These are listed in all of your RAs, and ensure you're billing effectively for that care. And when I say billing effectively for it, I mean learning the codes that contribute to kicking out the bonuses. Ensure you're rostering your patients in the FIG to allow for a smooth transition to the FHO. And above and beyond just a smooth transition, that is currently money being left on the table for all of those patients that aren't rostered, because you do get access to the comprehensive care payment for those patients. And set up a smooth preventative care program within your practice to maximize bonuses available to you. Now, the preventative care program is the same from the FIG to the FHO. So why not make sure that the Prev Care program is really sort of humming along, so by the time you get to the FHO, you can really start to work on things like access bonus, the additional bonus and premiums available to you. These are things that you could do now to take your FIG practice to the next level. Within the FHO, consider transitioning to the FHO for income predictability, flexibility, and rewards for offering complex patient care. More than likely, you are already providing this care, so why not be paid more for providing that? Be aware that outside use is a daytime access issue. This is an important piece. It's not a weekend problem. So the access bonus, oftentimes when people transition from FIG to FHO and they say, I'll never work Saturday, Sunday, so I'm fine with giving up a piece of my access bonus. The weekends are not really what contribute to the access bonus driving down, because the A888 is billed on the weekend, which doesn't contribute to outside use. So really, it's a Monday through Friday daytime access issue. Also, you have the ability to de-roster retroactively in order to make informed rostering decisions. What I mean by this is that we can help you identify which patients it makes more sense to see on a fee-for-service basis. It's difficult to pull that activity out just by looking at the Ministry of Health reports. And once you have all of that information, you really are able to make really a data-driven decision, which we always encourage everybody to do. We take care of the business side of it. You take care of the medical side. So we will provide you with all of the list of patients that we think financially it means more sense for you to de-roster and see them on a fee-for-service basis. And it's up to you from a medical standpoint to make that ultimate decision. So that's what we've prepared for today. If anyone is interested in having a further discussion with me about your individual practice or setting up a group meeting to discuss the implications of transition for your specific group, please feel free to reach out to me directly. I will, over the next few days, I will also be following up with each of you to address your individual questions. Want to make sure that you really are getting the most out of today's program. And I really hope that you found this session helpful, and I look forward to speaking with everybody soon. Lastly, here's the contact information for myself as well as my team at Cirrus Consulting Group, and I look forward to speaking with you soon. Thank you.
Okay, great. Thanks, Andrea. We do have a bit of time for Q&A. I know we do have one question up here that maybe we can answer. There's a question, what is shadow billing?
Sure. So shadow billing is for all in-basket services provided to enrolled patients. So that means for all of the patients that are enrolled, every time that they come in for anything that's in basket, an AO03, an AO07, your sort of run rate services, you still get 15% of the fee-for-service value on top of the capitation. Now, one of the reasons why we really think that this program is in place, because it's really one of the only ways that the ministry has visibility into the care that you're providing to rostered patients. Without this, without shadow billing, really patients could come in and out of your office. You would still be paid through the capitation, but the ministry has no visibility into the actual care that's being provided. So that's what shadow billing is.
Perfect, thank you. And then there is one last question about what Cirrus charges. However, I'm sure on an individual basis you can connect with the folks and speak about that.
Of course, yeah. So, I mean, we work with individuals and on a group-wide basis. And I mean, it really depends on where the group is at and what you would be engaging us with. So we can take that offline. Happy to follow up about that.
Perfect. So if there aren't any other questions, we will end it there today. So again, thanks everyone for joining. We do have the information up on the screen to connect with Andrea, as well as we will be sending out a follow-up with the recorded, or a link to the recorded webinar that you can follow up, as well as the presentation that we've had here today. Oh, one more question to come up. Do you have time just for one more question, Andrea?
Sure,
okay.
Yeah.
So the question is house call out of the basket, or house call out of the basket?
Yeah, so house call. Yeah, so B966, B960 to 64, all of these are at a basket. Home visits are one of the other categories too, where there's a bonus attached to it. So always wanting to make sure that billing properly for those home visits to ensure that that's giving you access to the bonus as well. There's a bonus for home visits of upwards of $8,000 if you're doing a number of home visits within a year.
Perfect. And then one more. How would a new graduate benefit when they do not yet have a roster?
Sure. So a new graduate, I mean, there are, in terms of people retiring, I mean, we're working with even a number of people that are on the verge of retirement. We find that the FHO is a great way for people to, when they're retiring, they like the fact that they're in the FHO because it's easier for somebody to take over their practice, because it's basically a salaried portion of income that a new grad or somebody would be taking over. There is also a program available through the Ministry of Health called the Income Stabilization Program, which in a patient-enrolled model, basically it's a fixed salary that is paid to the physician, and for that salary they basically have to hit roster targets every month in order to continue on that program, and it's for a year. So you have a bit of predictable income while you're looking to build up that roster before a transition.
Perfect. So we had a few more questions come up. Do we want to take a few more and then we'll sign off, or do we want to answer? Okay.
Yeah, I can take one more.
Okay, perfect. So one is, how does FHO physician is required to do the 3-hour block? Does every FHO physician required to do the 3-hour block?
So the after-hours blocks are based on the size of the group. So the after-hours blocks were actually increased in the last round of Ministry of Health negotiations, so it really depends on the size of the group. Every physician within the FHO, I've never come across anybody that's been able to get out of doing their after-hours call, but it really depends on the size of the group. So, for example, 3 physicians within a FHO have to offer 3 after-hours blocks from 5 to 8 p.m. within a week. 5 physicians, 5 hours. But more and more physicians, it does drive down a little bit the call requirements.
Okay, great. And how far back do we have to roster a patient? How far back can we roster a patient?
So, I mean, with the Ministry of Health, there's generally a 6-month sort of scale dating rule, and so you can go back 6 months.
Okay, and if the patient's seen a doctor in the FHO during the day, is that deducted from the doctor income? No. All FHO physicians, so the doctors within the FHO are encouraged to work together. So if a FHO patient, for example, if I went to my family doctor who's in a FHO and she wasn't able to see me that day, I would be able to go and see the other FHO physician that she works with, and that wouldn't impact either of their outside use ability. They would only get the shadow billing portion for seeing each other's patients, however. Okay, perfect. Now the last question, and then we'll sign off, everyone, is can Cirrus help us form a FHO? Yes. So, I mean, we work, really virtually at all stages. I can certainly take that question offline, but
whoever is asking that, please write down my contact information. I will be in touch with everybody, but it would be it'd be nice too if you could reach out to me and ask me your direct questions. Happy to provide some guidance on all of those pieces.
And what we can do is we can share all the questions and who asked the questions, and we can follow up that way as well.
Perfect. Great.
Okay, everyone, thank you so much again for joining. Andrea, thank you. And we will be reaching out to you guys over the next couple of days.
Great. Thank you. Thanks, everybody.
Thanks so much, everyone. Have a great afternoon.
Bye-bye.